So the question is there potential for rebiopsy at multiple time points at progressions? I think it's not only feasible, it's desirable to do that. Now we routinely recommend to patients that they be rebiopsied, and we have educated our interventional radiologists and pathologists who initially used to be shocked by us sending a patient for a biopsy whose diagnosis is already established. Previously, cancer patients used to get one biopsy in the natural history of their cancer, and now we are doing repeat biopsies upon progression, especially in patients with driver mutations, to see what type of resistance mutation has developed, especially in an era where we have multiple lines of targeted therapy available.
It's a big concern about using the second generation TKIs and potentially inducing resistance mutations perhaps a bit earlier, but it's all theoretical. We haven't actually seen this in practice. The fact that we are seeing a doubling in progression-free survival, 16 plus months for ceritinib compared to historic control of 8 to 10 to 11 months with the crizotinib in frontline, minimum median PFS of over 20 months in the JALX trial for alectinib, strongly suggests that at the very least we are delaying the onset of resistance mutations, or perhaps circumventing resistance mutations. We simply lack the data. We need to prospectively assay these individuals, get serial biopsies, serial blood samples, and really determine whether resistance mutations are actually occurring.
Each of the next generation ALK inhibitors appear to have activity in the CNS far superior to what has been observed with crizotinib. And when we look at the outcomes of patients who are treated with crizotinib, up to 70% of the patients can develop brain metastases during the course of their illness. That number, that percentage appears to be much lower with each of the next generation ALK inhibitors, suggesting that these drugs are not only treating patients who have evidence of CNS metastases, but also maybe preventing the development of CNS metastases. Now, that is somewhat speculative, and it's an extrapolation of the data. But the major implication is both in terms of morbidity and, I believe, mortality. CNS metastases can be a big issue, a big reason for symptoms and symptomatic deterioration. In addition, in the past, the only treatment we had for patients with brain metastases was whole brain radiation. Now we do treat patients with stereotactic radiosurgery, but each of those modalities do have side effects, including cognitive impairment. Having now a drug that doesn't utilize radiation to the brain, having drugs rather that do not require us to use radiation to the brain is, I believe, a major advantage in that we are reducing the morbidity from those treatments, as well as from the occurrence of brain metastases. And my suspicion is, and this is at the present time only speculative, that by controlling brain metastases, we are likely to improve survival. So I feel the major advance with these next generation ALK inhibitors is their ability to treat and possibly prevent CNS metastases.